Now in this session, we are going to have examination of the abdomen. The examination of the abdomen for proceeding the abdomen for the abdomen proper, we first go for the general physical examination relevant to the abdomen. Now, uh, again, this general physical examination relevant to abdomen is divided into a few segments. We examine the hand, we examine the face of the patient, we may examine the chest, and sometimes we may examine the feet as well. So, uh, we start. My name is Professor Imran, and I am going to examine your abdomen.
Yes.
If you have any problem during that, let me know. I, I will try to be very gentle. If there is any pain or discomfort, you can tell me, and we can change accordingly. Now, when you examine the hand, you see, examine the hand for the presence of clubbing, because abdominal conditions like inflammatory bowel disease or cirrhosis can be associated with clubbing, and also the malabsorption syndromes like celiacs, they have clubbing. And then chronic liver disease may be associated with palmar erythema. And then you can see for the presence of flapping tremor that is seen in hepatic failure. From the hand, you start going upward and look for the presence of jaundice. You look for on this side, look for the presence of pallor. Look upwards. Can you show me your tongue? Okay. Please open your mouth. So examination of the oral cavity in abdominal examination is very important, because this is part of the gastrointestinal tract, and many conditions may have a problem which can result in changes in the oral cavity. So always examine the oral cavity in patients when you're examining the GI tract. And then you look for the presence of spider angiomas. The spider angiomas are dilated tortuous blood vessels present just under the skin in the shape of a spider, and they are seen in the distribution of the area of drainage of superior vena cava. That is, they are present above the nipples in the male, and uh, they indicate underlying chronic liver disease. So they indicate cirrhosis of the liver. And when you are examining the face, you also note down what's the state of the parotid glands. Are they enlarged or are they normal size? And then you come to the chest, look for the spiders, look for the presence of gynecomastia. Similarly, you should examine the lymph nodes, because many abdominal conditions may be associated with enlarged lymph nodes. And then look for the presence of dependent edema that may be present in a disease like cirrhosis of the liver. Sometimes they may be present in conditions like malabsorption when there is hypoalbuminemia. And then we come to the examination of the abdomen proper. So we go for examination through all those four steps, that is inspection, palpation, percussion, and auscultation. Again, when we examine, we do the inspection, we need a proper exposure. The exposure generally is recommended is from mid chest to mid thigh, but you see in many circumstances, depending upon the socio cultural or religious background of the patient, it may not be possible to expose the patient for uh, abdominal examination, and we have to examine in a compromised situation. But if the examiner thinks that it is important to examine the groin or the genital areas, then a special consent can be taken and patient can be examined, or patient can be examined by the physician of the same sex after having consent from the patient. So we are proceeding in the examination of this patient with this much exposure. And when we are doing inspection, we look at the uh, number one, shape of the abdomen. Normal abdomen is scaphoid shape. This abdomen is slightly protuberant. We look for the umbilicus. It is central, or it is eccentric, it is inverted, it is everted, or flat. And then we see the presence of superficial veins. And if the veins are present, note down the pattern. Are they present in the central portion or they are present in the peripheral portion. Then we should look for the surgical scars. And finally, look for the presence of any pigmentation, and if any peristaltic waves or any pulsations or any bulging areas are visible, look for the presence of these. And when you have examined from this area, you should always bend down and see the abdomen like this, because you see, you cannot have a full idea of any event which are going on at 90 degrees to your field of vision. You see, always see the abdomen at the tangent, because it's easy to see any events which are going on a tangential plane. So look for the abdomen like this. And then have an examination from the foot end to look for the symmetry, because symmetry cannot be seen on the side, it is seen always from the foot end. And when you have done this, also note that how is the abdomen moving? Is it moving with respiration normally? You see, normally what happens in inspiration, the abdomen moves down, and in expiration, it moves up. In patients who've got bilateral diaphragmatic paralysis, this is opposite. In inspection, the abdomen is sucked upward, and in the expiration, it moves downward. So look for the movement of the abdomen as well. And then we go for palpation. And when you are going for palpation, just keep in mind that your hands should not be very cold, because if you touch with cold hands, patient will guard and you will not be able to palpate normally. And before palpating, always ask patient, are there any painful areas in the abdomen? Do you have any pain anywhere in the abdomen?
No.
No. So always ask for this. And then when you are examining, your hand should be on the abdomen and your eyes should be on the patient's face, because your examination should not cause pain to the patient. So we start it like this, and we have a superficial palpation. Just sweep your hand across the abdomen and try to feel if there are any tender areas or any mass or any pulsation that may be palpable. That will guide us for further examination. And then we have done this superficial palpation, then we go for a deep palpation. Deep palpation generally means you go for an organ palpation and you go for a generalized palpation. For the organ palpation, we examine the liver, the spleen, the kidneys, and the urinary bladder, or the pelvic organs in the female. Now, how we examine the liver? What we see, try to examine liver on the outside of the rectus. So how to locate the rectus? So you just ask the patient to lift the head against the resistance. Can you lift your head? Sir, upar uthao, sir, upar nahi, upar bistar se upar uthao. Like, bas. So you locate the rectus and always palpate on the outside of the rectus. So what you do is you just bend like this and you start palpating and ask the patient to take deep breaths. Lambe saans lo. And if you don't feel it here, then try to feel it here, because in some condition, only the left lobe may be enlarged. For example, in tumors, or if there is the beginning of chronic hepatitis, the left lobe may hypertrophy first and then the right as well. So when you find out the liver, if it is palpable, you just mark it and then you start percussing. You mark it with a skin pencil and then you percuss from above. And locate the upper border, and then you measure what is the percussion span of the liver. So this is how we proceed for the liver. That is, you start from the right iliac fossa, ask the patient to breathe and see if the liver comes and strikes your hand. And when you feel the liver, you just note down, is it tender, it's non-tender, how is the edge, it is sharp, rounded, or nodular. And if you can feel a large liver, then you should feel over it that is this liver nodular. Next, we examine for the spleen. Spleen is present in the left hypochondrium. Generally, it is recommended that for splenic enlargement, we should start examining from the right iliac fossa and move diagonally. But my experience is that if you do a general palpation, that tells you, the superficial palpation, that tells you that is there a splenic mass or not. If you feel there is a splenic mass, we may start from right iliac fossa, but if you don't feel anything on superficial palpation, then we may start simply from the umbilical region and see what's the size of spleen. But we start in this patient from the right iliac fossa. Ask the patient to have deep breaths. And you see, many of the students I have seen, they just try to move their hand along with the breathing. I don't recommend this. You just put your hand and ask the patient to breathe. Anything which is moving with respiration is going to come and strike your hands. So when you examine the spleen, you just examine the whole subcostal area, because spleen may sometimes enlarge very asymmetrically. You may find a splenic enlargement here, or sometimes you may find it here. So you see, I don't feel any spleen here. So if you don't feel a spleen here, you can do a couple of maneuvers. For example, you do a bimanual palpation. You just lift the rib cage. And just lift the rib cage and ask the patient to take a deep breath and feel if it's there. Or if you can't feel even with this maneuver, you can turn the patient to the right side. Right line. And then you can feel it. But if you don't feel it like this is likely not to be a splenic enlargement big enough to be clinically palpable. And keep in mind, spleen may be big, still not palpable, because if it becomes more than almost 2.5 times of its normal size, it becomes palpable. So even an impalpable spleen may still be enlarged, but this generally does not happen with the liver. And when you find a splenic enlargement, you see, sometimes you calculate the splenic span. Now, how do you calculate that splenic span? Is by drawing a perpendicular. You take the farthest point on the spleen, you draw a perpendicular from the subcostal margin to that area, and this is the splenic span. For example, if the spleen is present here, you draw a perpendicular from this subcostal margin like this, and you can document what is the splenic size on clinical examination, which can be followed subsequently as you treat the patient. Is it enlarging or is it regressing inside? And then the next important organ to be examined is the kidneys. We examine both the left kidney and the right kidney. And the examination is that you examine the right kidney in this area. You just see the renal hilum. Renal hilum is actually lying at the subcostal plane approximately. And the subcostal plane is, you can see, this is the subcostal plane. And the renal artery is pretty small, it's about a couple of centimeters. So you find this is from almost an inch or so away from the midline, the renal hilum, and below that you find the renal masses. So you just palpate in this area. I've seen a lot of students examining the kidneys here. You can't find kidney here. It's closer to the midline rather than that far away. So you should put your hand closer here and the other hand underneath it. And so this is called bimanual palpation. You press from the left hand the rib cage and try to lift the kidney up, and then ask the patient to take a deep breath. And similarly, you can examine the left kidney like this. Then lift from the left hand the rib cage and then feel the movement of the kidney with the respiration. And then finally we do a palpation of the organs, that is the urinary bladder. Urinary bladder can be examined with the left hand like this, or it can be examined with both hands like this. Similarly, the pelvic organs in the female can be examined like this if you can find a lower abdominal mass. The lower limit of the urinary bladder and the uterus cannot be found because they are coming from inside the pelvis. So if any mass is above the pelvis, you can find the lower limit of it. And similarly, you cannot put a finger between the costal margin and the spleen. Now, there is most of the time a question in the examination, how do you differentiate between the left kidney and this spleen? So there are few differences in the examination of where you can decide this is spleen or this is kidney. Number one, kidney is bimanually palpable. Spleen may not be, it can be palpated simply. Spleen has a sharp border. You may feel a notch on it. and you cannot put your fingers between the splenic mass and the rib cage, while that you can do that in case of kidney. And the percussion note over the spleen is dull, while the percussion note on the kidneys is resonant. So this is how we differentiate the renal mass from the splenic mass. And then you do a general palpation, general deep palpation. If you can find any mass or any deep tender areas. So if you don't find anything on deep palpation, and then you look for the abdominal lymph nodes. If there's a gallbladder mass, you can palpate the gallbladder mass and look for the aorta. The aorta is present here, just finishes just above the left of the umbilicus, and with this poking maneuver, you can feel the abdominal aorta. And similarly, you can feel the lymph nodes on deeper palpation. So since this is maybe a painful part of the examination, so this should generally be done at the end. And if you find a globular mass here, then you should try to see if it moves from side to side. If it moves from side to side, it may be a gallbladder. In the same area, we may have enlargement of the caudate lobe of the liver, which usually does not move from side to side. So if this mass can be moved side to side slightly, this most likely is gallbladder. And then in the end, if you're considering the abdomen as very distended, then look for the presence of fluid thrill. What you do is you just put your hand here and tap from here, and you see for a fluid thrill. In patients who've got a lot of fat, there may be a false transmission of this impulse through the fat. To obliterate that, you request the patient to put a hand here, or one of your colleagues to put a hand here, so that this can be damped, and then you can feel that pulsation. So you ask the patient to put the hand here, and then you do it like this. So look for the presence of fluid thrill. That's T. And then you go for percussion. Percussion is an important step, particularly confirming the findings of the examination on palpation. So we do examine the percussion over liver, over the splenic mass, over the urinary bladder, and if any mass is palpable, we do percuss over it to see it is gas containing or it's not gas containing. For the liver, we proceed from here. For renal masses, we percuss like this. And then we can percuss over the pelvic masses. And finally, we do a shifting dullness test. Shifting dullness is extremely important. It tells about the free fluid which is present in the peritoneum. So for the shifting dullness, we start from the epigastrium. And then we move towards the flank. If you find dullness, then you ask the patient to turn on the other side. Hold for some time so that the fluid, if it is present, moves downward. And then you percuss it again. If the dullness has disappeared, that means you have shifted the dullness. This is called shifting dullness. So this shifting dullness indicates the presence of free fluid in the peritoneal cavity. After this percussion, we go for the auscultation. Now, what we like to see on auscultation of the abdomen is the presence of the bowel sounds and any abnormal vascular sounds which are audible. So to hear for the bowel sounds, we generally auscultate at the McBurney's point, note down the intensity and the frequency of the bowel sounds. And you cannot say that bowel sounds are absent unless you have listened for at least 1 minute. Even if it requires more time, just go for confirmation of the presence or absence of bowel sound. And then you can auscultate for any abnormal vascular sounds. For example, In the epigastrium, we auscultate, we may find bruit because of the renal arteries stenosis, or may find the bruit of the abdominal aorta if there is an aortic aneurysm. And if there is an aortic aneurysm, we do a maneuver to see. For example, if there are pulsation visible in the epigastrium, what we do is we put our fingers here and see how the fingers are moving. If they are moving like this parallel up and down, this is a transmitted pulsation. If the fingers, in addition to moving upward, they also separate a little bit. So this means this is not a transmitted pulsation. This is because of the aortic aneurysm. So this is what we do on examination of the patients who are presenting with the abdominal symptoms. And in the end, we request to do a rectal examination and examination of the genitalia and the hernial orifices. For that, you have to make the patient stand. And if you think patient has problem in these areas, as I already mentioned, you should have a special consent. And if you are examining a patient of opposite sex, it should be accompanied by a chaperone or be examined by one of your colleagues of the same gender. So that's how we go for our examination of the abdomen. Thank you, Shabir.
Well,